presented by NAF Medical Services. The next 9 slides contain valuable information about this Internet enduring material. There will be no audio. Audio resumes on slide 11, Learning Objectives.
In 2014, the National Abortion Federation developed a training module used to supplement the education of nurses and physicians who are not anesthesiologists or anesthetists and who manage patients receiving moderate sedation in the abortion setting. The course objectives are designed to help the participant to prepare patients for sedation, including performing a pre-sedation assessment, acquiring consent, and develop an individualized plan for sedation, administer and monitor the patient undergoing moderate sedation while adhering to specific guidelines, plan for and address special needs and respond appropriately to emergency situations, monitor patients during the post-procedure recovery period, and discharge patients appropriately. In addition to the objectives outlined in this module, participants should also supplement their knowledge by 1. Establishing proficiency in basic airway management, 2. Maintaining healthcare provider level BLS certification, and 3. Familiarizing themselves with the pharmacology of medications used in their practice, as well as any reversal agents that could be employed. Appropriate training in the provision of moderate sedation is required for anyone wishing to undertake this task, as basic education in either nursing or medicine does not cover the specifics of such care. So what is moderate sedation? Moderate sedation is a level of sedation that occurs on the continuum of sedation as defined by the American Society of Anesthesiologists. This falls somewhere between minimal sedation and deep sedation. Moderate sedation is a drug-induced depression of consciousness during which patients respond purposefully to verbal commands, either alone or accompanied by light tactile stimulation. No interventions are required to maintain a patent airway, and spontaneous ventilation is adequate. Cardiovascular function is also usually maintained. This level of sedation was previously referred to as conscious sedation. However, this term is no longer recommended. Most patients in the abortion setting can be comfortably accommodated with this level of sedation. Alternative modalities, such as the presence of a support system, talking, visualization, and hypnosis, can also help augment the sedative effects in women undergoing an abortion with moderate sedation. So what are the requirements of personnel administering moderate sedation? In order for an individual to demonstrate competence in the provision of moderate sedation, there should be documentation of the following. 1. The individual administering such sedation should be appropriately licensed and maintain healthcare provider level BLS certification. Ideally, there is someone with ACLS certification on site, but this is not a requirement within the NAF clinical policy guidelines. 2. There must be documented proficiency of airway management skills and the ability to provide adequate oxygenation and ventilation if needed. 3, one must be proficient in the monitoring of patients during the procedure and recovery and have the ability to rescue patients from deep sedation if needed. And lastly, there must be knowledge of medication pharmacology for both medications used during sedation and their appropriate reversal agents if available. Because sedation occurs on a continuum, it is not always possible to predict how an individual patient will respond. Hence, practitioners intending to produce any level of sedation should be able to rescue patients whose level of sedation becomes deeper than initially intended. Rescue corrects adverse physiological consequences of the deeper than intended level of sedation, such as hypoventilation, hypoxia, and hypotension, and returns the patient to the originally intended level of sedation. When patients are under an appropriate level of moderate sedation, they are cooperative, conscious, their anxiety is controlled, amnesia may be present, vital signs are stable, their protective reflexes are still active and intact, and there should be no reasonable expectation that there will be a loss of airway reflexes. Moderate sedation offers a low risk of complication, and there are often none to infrequent post-sedation complications when such a level of sedation is maintained. Although moderate sedation is generally a safe way to help manage pain in women undergoing abortion, there are some conditions which increase the possibility of adverse events. All of our patients will be pregnant. Depending on the gestation of the pregnancy, the risk of moderate sedation are variable. We will review this later on within the module. Additional risk factors include uncooperative patients, patients with severe cardiac, pulmonary, hepatic, renal, or central nervous system disease, morbidly obese patients, patients with obstructive sleep apnea, patients with a history of drug and/or alcohol abuse, and women with upper respiratory infections such as airway disease or asthma. Before offering moderate sedation to the patient, there are a number of steps which should be accomplished. The first step for patients receiving moderate sedation is obtaining informed consent. This process should include both a written and verbal review of the risks, benefits, and alternatives of care. Ideally, this information should be included on a document separate from the procedural consent form. The next step in this process involves evaluating patients for eligibility. This will include a history and review of systems with particular focus on cardiac or pulmonary problems, allergies, medication use, history of adverse reactions to anesthesia or sedation, and any recent or past drug use and/or alcohol use. A targeted exam should be performed, which includes an assessment of the heart, lung, and airway. NPO status should be documented, as well as the patient's eligibility using the ASA physical classification system. Baseline vitals should be obtained, as well as any relevant lab work. When obtaining informed consent, the major risks of analgesic, sedative, or anesthetic agents, including paracervical block, should be both in writing and reviewed verbally as part of the consent for aspiration. For local anesthesia only, these would include allergic reaction, cardiovascular and respiratory compromise, arrest, and death. With sedation, this list would also include phlebitis, unanticipated depth of sedation, and with midazolam, the significant side effect of amnesia. Because moderate sedation has the potential to compromise airway patency in patients, it is important to recognize those women in whom a higher risk airway already exists. History may reveal that patients had a previous issue with sedation, anesthesia, or airway management. Questions about sleep pattern may reveal a history of stridor, snoring, or sleep apnea. Advanced rheumatoid arthritis has the potential to compromise airway, as well as any abnormal anatomy such as head or neck tumors. Some obese patients run a higher risk of airway compromise, as well as those with any congenital syndromes that involve the airway, or those with a history of radiation or surgery to the head or neck. Physical exam may reveal factors associated with difficult airway management, such as a BMI over 35 or a short neck. Otherwise, a small mouth opening or receding chin, abnormal cavity inspection may show enlarged tonsils, multiple dental caries, or protuberant incisors or loose teeth. If there is any question about a difficult airway, it is probably best to proceed with a lesser degree of sedation or consult with an anesthesia professional. Giving each patient a Mullen-Patty score can help to classify which airways are appropriate for moderate sedation in the outpatient abortion setting. Class 1 airways allow for complete visualization of the uvula and soft palate. With Class 2 airways, you are still able to visualize the entire uvula. In Class 3 airways, only the base of the uvula can be seen, and in Class 4 airways, it is not possible to visualize the soft palate at all. Class 3 and 4 airways, during this time, a reduction of sedation, alternative abortion procedure such as medical abortion, or provision of care by an anesthesia professional should be considered. Another way patients should be screened for moderate sedation eligibility is with the ASA Physical Status Classification System. There are 5 levels of classification based on the degree of physical status. ASA 1 individuals are normal, healthy patients with no systemic disease. ASA 2 individuals may have mild to moderate systemic disease. For example, this may include controlled hypertension, controlled diabetes without systemic effects, mild obesity, or tobacco use, or, as the Cleveland Clinic has suggested, pregnancy. Consideration of an anesthesia professional should be considered in anyone in Class 3 or above. These include those with conditions considered to be severe systemic disease, such as poorly controlled hypertension, morbid obesity, or bronchospastic disease with intermittent symptoms, amongst others. While sedation does occur on a continuum and is not defined by the method of delivery per se, this table classifies the level of sedation based on physiologic parameters as exhibited by the patient. Minimal sedation, or anxiolysis, is a drug-induced state during which patients respond normally to verbal commands. Although cognitive function and physical coordination may be impaired, airway reflexes, ventilatory, and cardiovascular functions are unaffected. Moderate sedation is a drug-induced depression of consciousness during which patients respond purposefully to verbal commands, either alone or accompanied by light tactile stimulation. No interventions are required to maintain a patent airway, and spontaneous ventilation is adequate. Cardiovascular function is usually maintained but may be impaired. Deep sedation is a drug-induced depression of consciousness during which patients cannot be easily aroused but do respond purposefully to repeated or painful stimulation. The ability to independently maintain ventilatory function may be impaired. Patients may require assistance in maintaining a patent airway, and spontaneous ventilation may be inadequate. Cardiovascular function is usually maintained but may be impaired. General anesthesia is a drug-induced loss of consciousness during which patients are not arousable even by painful stimulation. The ability to independently maintain ventilatory function is often impaired. Patients often require assistance in maintaining a patent airway, and positive pressure ventilation may be required because of depressed spontaneous ventilation or drug-induced depression of neuromuscular function. Cardiovascular function may be impaired. It is important to note that reflex withdrawal from a painful stimulus is not considered a purposeful response. Depending on the medication regimen utilized within your facility, you'll need to educate yourself about the pharmacology of these drugs prior to administering moderate sedation. This chart only samples a small portion of medications utilized at various member facilities. By and large, the most common combination of medications utilized for the purposes of moderate sedation are fentanyl and midazolam. This is due in part to the rapid onset and shorter duration of these medications. It is important to note that the potential drug effects and special considerations listed in this table are not exhaustive, so supplemental education in the specifics of the medications used at your facility is required for competence. In general, it is important to review the initial IV dose and frequency of any further doses that may be required, the onset of action, their peak, and the duration of effect. The potential drug effects of medication should be reviewed, as well as any special considerations that should be given to that medication regimen. One should always be aware of the pharmacology and availability of any reversal agents that could be employed at the time of an emergency. Because there are a number of regimens employed by facilities, I'll take the time to review the most common regimen, that of fentanyl and midazolam. Fentanyl is an opioid with a fast onset and short duration of action. It can be used to provide analgesic relief during the procedure. An initial dose of this medication should begin at 50 to 100 micrograms, depending on the patient. Additional doses of 25 micrograms may be administered at 2 to 5 minute intervals until sedation is achieved. However, because of the short duration of most abortion procedures, an initial dose is often enough to cover the needs of your patients. The time of onset for fentanyl is between 1 to 2 minutes, and this peaks at approximately 3 to 5 minutes. The entire duration of action is between 30 to 60 minutes. Like any opioid, fentanyl can cause respiratory depression, hypotension, apnea, blurred vision, and nausea and vomiting. It is important to administer this medication slowly, as rapid infusion may lead to chest wall rigidity or seizures. Patients still need to be monitored in recovery, as the respiratory depression can outlast the analgesic effects of the medication. The reversal agent for fentanyl is naloxone, or Narcan. Versed is a benzodiazepine that is often used in conjunction with fentanyl in providing moderate sedation. Like fentanyl, it too has a rapid onset and short duration of action. Versed can be used to provide anxiolysis during procedures and has the benefit of providing a period of amnesia to its recipients. The initial dose of Versed should be between 1 to 2 milligrams, with additional doses of 1 milligram to be administered at 2-minute intervals as needed. No more than 4 milligrams should be necessary. The onset of action occurs at 1 to 2 minutes, with a peak of 3 to 5 minutes, and duration of 50 to 80 minutes. Potential side effects of Versed include hypotension, respiratory depression, and this occurs especially when combined with opiates. It can also cause dizziness and blurred vision. Dosages should be reduced when combined with opiates. The dosages should be titrated slowly over 2 minutes, while allowing more than 2 minutes for the drug to take effect. When given with fentanyl, many people will administer the Versed first for this reason. The reversal agent for Versed is flumazenil or romazicon. Other medications used for moderate sedation include Valium and Demerol, amongst others. These medications have a much longer duration of action and therefore require a longer recovery period prior to discharge. Reversal agents are an important component of a safety regimen when delivering opioids and benzodiazepines. While it is certainly important to have these agents readily available, they should never be employed routinely. If patients regularly need reversal, they're being overly sedated. Reversal agents should only be employed when the patient's safety is at risk. Naloxone is an opioid antagonist that competitively binds to the opioid receptors. If the patient is apneic, it is recommended that the initial dose of 0.1 to 0.2 milligrams be administered, with additional doses of 0.2 to 0.4 milligrams every 2 to 3 minutes until the desired response is achieved, with careful monitoring. If the patient is not apneic but has a falling oxygen saturation, it is recommended that the Narcan or naloxone be titrated into effect. Complications of naloxone administration include the development of pulmonary edema and hypertension. In the apneic patient, it is important to remember to support the airway, and the first drug of choice is to administer oxygen. It is also important to realize that the patient may resedate since the half-life of naloxone is only about 20 minutes, and the half-life of most narcotics is longer than that. The agent used for reversal of benzodiazepines is flumazenol. Flumazenol binds to the benzodiazepine receptor. However, it does not affect other GABAergic agents such as alcohol or other barbiturates. It is administered by giving 0.2 milligrams intravenously over 15 seconds and then waiting another 45 seconds before repeating the dose. Up to 1 milligram may be given. Again, it is important to remember to support the airway and administer oxygen. The only precaution with flumazenol is to be careful of its use in patients with a history of seizures. Nitrous oxide requires the same attention to assessment and monitoring as all forms of moderate sedation. Patients must be screened for eligibility, and there must be a designated person assigned to monitor the patient throughout the procedure. Because of the risk of hypoxia, the nitrous oxide administration equipment must be set up so that the patient is able to self-administer. The equipment must be outfitted with an oxygen analyzer. Additionally, while no more than 50% nitrous to oxygen should be administered routinely, the equipment should be set up to ensure that no more than 70% nitrous to the patient can be delivered. Lastly, because of the risk of occupational exposure, there should be a way to conduct personnel monitoring. Occupational exposure to nitrous oxide is associated with increased risk of neurological impairment, spontaneous abortion, subfertility, and hepatic and renal disease. Employing scavenger systems and ensuring adequate ventilation will help reduce the risk of exposure, as well as delivering 100% oxygen to patients for 5 minutes before removing the mask. Monitoring of staff can occur through the use of dosimetry badges or infrared spectrophotometers. NIOSH recommends that nitrous levels remain below 24 parts per million. While there are alternative recommendations for preoperative fasting, and the choice for minimum fasting period can be facility-based, the ASA recommends a minimum of 2 hours for clear liquids and 6 hours for milk or a light meal. These are only recommendations, and it should be noted that pregnancy could delay gastric emptying. Before administering moderate sedation, it is important to ensure that the appropriate equipment is in place. There should be a system of ensuring equipment and medications are checked regularly for function and expiration. At minimum, the following are needed when moderate sedation is being administered. 1, an oxygen source and delivery system. 2, oropharyngeal airways in varying sizes. 3, bag valve mask capable of delivering supplemental oxygen. 4, an AED machine. 5, a pulse oximeter. 6, a blood pressure device and stethoscope. 6, crash cart with vasopressors including epinephrine, antihistamines, bronchodilators, and reversal agents. And 7, IV fluid. Patients should be well educated about the expectations of moderate sedation. In addition to describing the procedure and obtaining consent, it is also important to describe what sensations can be expected, because while patients may experience reduced anxiety and sleepiness, they will still be awake. Patients should know that they will be monitored throughout the procedure and that they may experience some memory loss related to the experience. Everyone who receives moderate sedation should have a responsible adult to accompany them home afterward. Just prior to the procedure, the following safety measures should take place. Verify correct identification of the patient, obtain baseline vital signs and oxygenation, and document. Review any factors that may affect response to sedation, including any airway issues, substance use, experience with sedation, physical status, and the results of any relevant diagnostic studies. Review allergies, check NPO status, check that all the monitoring equipment is in working order, review the provider orders, obtain moderate sedation medications and the reversal agents, establish and maintain working IV access, verify that the patient is tolerating the position for the procedure, confirm patient understanding and answer any last-minute questions, and then perform a safety pause or a timeout. Once the patient is ready for the procedure, ensure that the supervising practitioner is immediately available when the medication is administered. You'll want to ensure documentation of the name, dosage, route, and time of administration. If supplemental oxygen is delivered, the amount and means of delivery should also be documented. After administration, the patient should be checked for verbal responsiveness. Oftentimes, communicating with the patients will also help to reduce pain and anxiety. Take note of head placement and airway patency. Throughout the procedure, vital signs should be obtained to detect the respiratory, cardiovascular, and neurological effects of the medications being given. Pulse oximetry monitoring should be placed on the patient and monitored continuously. Levels should be documented along with other vital signs. Appropriate alarms should remain on. Even when pulse oximetry is being employed, ventilation needs to be assessed, as ventilation and oxygenation are two separate processes. A decrease in oxygen saturation is a late indicator of inadequate ventilation. Ventilation can be assessed through verbal communication with the patient, counting respirations, and feeling or listening for inspiration and expiration. In addition to the vital signs, any other significant observations should be documented. This could be any emergency interventions, IV fluid, or complaints of pain, amongst other things. Standard monitoring for moderate sedation includes the level of consciousness. She should be able to respond to verbal commands and light stimuli, oxygen saturation, heart rate, respiratory frequency and/or confirmation of adequate ventilation, and blood pressure. Ideally, these should be documented every 3 to 5 minutes. Even with continuous monitoring, it is still possible for complications to occur during moderate sedation. For this reason, those in charge of administering sedation and monitoring the patient should be familiar with facility-based protocols for the management of such complications. Moderate sedation usually have minimal influence on cardiovascular function. However, excessive drug dosages may affect blood pressure, or cardiovascular changes may come about as a result of a vasovagal syncope triggered by pain or fear. Should hypotension develop, staff can help encourage adequate perfusion by withholding further medication, administering fluid, and raising the patient's legs if possible. Ensure that adequate oxygenation is maintained. If symptoms do not resolve, vasopressors may be considered or a reversal agent as necessary. Respiratory depression may present as a decrease in depth and/or rate of ventilation and is attributed to depression of respiratory control centers, which normally trigger breathing as carbon dioxide levels in the blood rise slightly above the normal threshold. All have the potential to depress central hypercapnic and/or peripheral hypoxemic drive, but this risk is minimal with moderate sedation, provided one uses conventional doses and monitors the patient appropriately. Nevertheless, one must be thoroughly skilled in managing respiratory depression in the event it should occur. The lack of response to a verbal stimuli is generally the first sign that there is impending respiratory depression. The first measure one should take is to stimulate the patient to wake up and take deep breaths while administering supplemental oxygen. Ventilation is integral, which is why only administering oxygen is not adequate. Ensure the airway is adequately open with a jaw thrust and chin lift. Pharmacologic reversal of the sedative agent is indicated whenever you are faced with an unconscious patient, since airway complications such as laryngospasm, airway obstruction, aspiration, etc., may result in apnea or failure to respond adequately to oxygen supplementation and attempts at positive pressure ventilation. Among the drug classes used for sedation, opioids are the most likely to cause respiratory depression. If an opioid has been included in the regimen, naloxone or Narcan should be the first reversal drug administered. If there is still no response, a bag valve mask and potentially the insertion of an oral pharyngeal airway may be necessary. At this point, EMS should be called. Airway obstruction must be distinguished from respiratory depression. Although obstruction may result in hypoventilation, the patient's actual drive to breathe may or may not be affected. Symptoms of partial airway obstruction include snoring, retraction of the sternum, stridor, rocking motion of the chest not in sync with respirations, hypoxemia, and hypercarbia. Symptoms of complete airway obstruction include lack of any air movement perceived by feeling with the hand over the nose and mouth, lack of breath sounds, rocking motion of the chest not in sync with respiratory effort, hypoxemia, and hypercarbia. Sedation drugs can interfere with ventilation by relaxing the airway muscles and suppressing the urge to breathe. The primary risk related to sedation is respiratory complications. Airway obstruction may also result from laryngeal spasm or laryngeal edema. Laryngeal spasm is a reflexive closure of the glottis muscles triggered by a foreign object or secretions. The airway should be suctioned, followed by a forceful jaw thrust to open the airway, and the bag valve mask should then be placed with enough force to establish a tight mask seal. Gentle continuous pressure from the bag should be applied until ventilations are successful. Pharmacologic reversal of sedative agents are indicated whenever you encounter an unconscious patient or when airway complications such as laryngospasm are diagnosed or even suspected. Those in charge of administering and or monitoring the patient undergoing moderate sedation should have separate training in basic airway management outside of this module. As a review, if the patient becomes overly sedated, the muscles of the tongue and mouth floor can relax with the tongue lying close to or on the back wall of the oropharynx. The epiglottis may obstruct the glottic opening or seal against the back wall of the pharynx as well. The chin lift jaw thrust maneuvers can be performed to relieve the obstruction and improve airflow. Jaw thrust moves the tongue forward with the mandible, which reduces the tongue's ability to obstruct the airway. Standing at the head of the bed, the middle finger of the right hand is placed at the angle of the patient's jaw on the right. The middle finger of the left hand is similarly placed at the angle of the jaw on the left, and an upward pressure is applied to elevate the mandible, which will lift the tongue from the posterior pharynx. The head tilt chin lift. The fingers of one hand are placed under the mandible, which is gently lifted upward to bring the chin anterior. The thumb of the same hand depresses the lower lip to open the mouth. Do not use the thumb to lift the chin. One hand is placed on the forehead to tilt the head back. The oropharyngeal airway is a curved, firm, hollow tube, usually plastic, with a rectangular opening that is used to maintain a conduit between the mouth and the glottis and to prevent obstruction by the tongue and other soft tissue. Oropharyngeal airways come in various sizes. All airways have a straight bite section that rests against the patient's lips and a flange on the proximal end to prevent over-insertion. Oropharyngeal airways should be used in unconscious and unresponsive patients because they're quite stimulating and can generate a gag reflex. In responsive patients, these airways can cause vomiting and aspiration. Incorrect insertion of an airway can push the tongue into the back of the throat, causing airway obstruction, as can using an incorrectly sized device. A device that is too small is ineffective and can be lost in the oropharynx. A device that is too large can press against the glottis and obstruct the larynx, causing trauma to soft tissue by catching on the tongue or lips between the airway and teeth. These are illustrations of both the head tilt, chin lift, and jaw thrust maneuvers. This is a picture of both the oropharyngeal and nasopharyngeal airway. Training on the correct insertion of these should be considered supplemental training to this module. Some other complications that may occur with the administration of moderate sedation include paradoxical reactions, nausea and vomiting, allergic reactions, or cardiac changes. Again, these complications are uncommon, but it is important to be aware of their potential and necessary response. Paradoxical reaction can occur in reaction to benzodiazepines and can include excessive talkativeness, movement, and emotional release. These reactions are relatively uncommon, occurring in less than 1% of cases. The addition of extra doses of benzodiazepines and opiates will usually worsen the problem. Flumazenil has been shown effective in managing these reactions. Nausea and vomiting may occur, often in response to opiates. Always have suction available. Patient's head should be turned to the side with emesis due to the aspiration risk. Allergic reactions may be mild or severe. With any allergic reaction, it is important to ensure that the airway is maintained and to notify the physician. Medication should be administered as indicated. This may include an antihistamine, steroids, and/or epinephrine. Any suspected cardiac changes should be treated as an emergency, and additional support should be ascertained. Pregnancy is considered a special circumstance when moderate sedation is being administered. Since all patients are entering the procedure in various stages of pregnancy, it is important to understand how this may affect the provision of care. In general, the risk of sedation vary based on the gestational age of the pregnancy, i.e. the later the gestational age, the more potential for complication. In general, the following anatomic and physiologic changes may impact the delivery of sedation. 1. Nasal and mucous membrane engorgement. 2. Airway compromise. Pregnant women are at higher risk of having a difficult-to-manage airway. For example, a pregnant woman with engorged nasopharyngeal and larynx tissues may require a smaller endotracheal tube than normal. Supplemental oxygen should be readily available and utilized early. 3. Compensatory increase in minute ventilation and increased oxygen consumption. 4. Increased heart rate and cardiac output. And 5. Decreased GI motility. There are times when a patient may also be breastfeeding. The primary concern related to sedation when a woman is breastfeeding is the risk of transferring drugs to the infant through the breast milk. In cases where the medication may be harmful to the infant, the woman should be advised to pump her breast milk and discard it, with the timing dependent upon the agent of concern. With mepridine or Demerol, it is concentrated in breast milk for up to 24 hours after administration and may have neurobehavioral effects on the breastfed infant. In this case, you should use fentanyl as an alternative if possible. With midazolam, the effects of the drug on the infant are unknown. Infants should not be breastfed for at least 4 hours after maternal midazolam administration. With fentanyl, breastfeeding may be continued after maternal administration. Excretion in breast milk can occur, but in very low concentrations for up to 10 hours after the administration. There is no information on the safety of naloxone and flumazenil in this setting, however. As part of the initial workup, patients should be assessed for a history or possibility of obstructive sleep apnea. The majority of patients with sleep apnea will not have received a formal diagnosis. Therefore, many times the possibility of sleep apnea should be assessed based on the patient's physical characteristics, in particular upper body obesity, medical history, family history of snoring, or abnormal sleep patterns. Obstructive sleep apnea is suspected when a patient reports both snoring and excessive daytime sleepiness. Approximately 12 to 18 million Americans have this condition. One survey estimated that 82 to 92% of people with moderate to severe sleep apnea are undiagnosed. The undiagnosed sleep apnea patient may be particularly challenging if the sedation regimen does not factor in that patients with sleep apnea are at greater risk of airway complications when they receive anesthetic, analgesic, or sedative medications. Some patients who do not otherwise appear to be at risk for sleep apnea may in fact be due to enlarged tonsils, for example. The converse can also occur. Not every large patient with a thick neck necessarily has obstructive sleep apnea. The administration of IV sedatives increases the muscle tone of the upper airway and increases airway resistance, resulting in a reduction of the diameter of the upper airway. These effects can lead to airway compromise in people with sleep apnea who already have an anatomically compromised airway. Any suspicion that a patient may experience a compromised airway during moderate sedation warrants either a decreased level of sedation or referral to an anesthesia professional. Some patients may, however, be difficult to sedate. Patients at higher risk for this include a history of sedation difficulty, benzodiazepine or opiate use, heavy alcohol use, biliary dyskinesia, morbid obesity, patients with a history of chronic pain, and patients with conditions such as dementia, paranoia, or anxiety. Difficult to sedate patients may require general anesthesia or deep sedation by an anesthesiologist or an anesthetist if they are otherwise unable to tolerate the procedure. Once patients have completed the procedure, they should be stable for transfer to recovery. More importantly, they should remain with appropriately trained personnel until they are no longer at risk for respiratory compromise. Patients should remain with appropriate personnel in recovery and be continuously monitored by someone trained in post-procedure care. This person should be able to recognize deviations from established parameters. Aftercare should have monitoring equipment and resuscitative equipment. A clinician who is capable of managing complications, establishing an airway, and administering positive pressure ventilation should be available until discharge. Patients should return to an acceptable level of functioning before being discharged. Patients should be monitored for a minimum of 30 minutes and at least 3 sets of vitals, usually beginning, middle, and end. Oxygenation should be monitored until patients are no longer at risk for hypoxemia. Patients can be discharged when they have returned to pre-procedure norms. If the patient received a reversal agent, an extended recovery period should be expected, which can be up to 2 hours. This is because once the reversal agent has worn off, respiratory depression can reoccur. Patients must meet discharge criteria before going home, and discharge instructions should be provided in verbal and written formats with clear patient understanding noted. Upon discharge, all patients need to receive verbal and written instructions and follow-up instructions. For the next 24 hours, patients should not make any important decisions, should not drive an automobile, consume alcoholic beverages, or do anything that requires significant mental concentration. A 24-hour contact number should be provided to the patient in the event of complications. Upon discharge, the patient must be released only into the care of a responsible adult who can accompany her home. Thank you for completing the National Abortion Federation's Moderate Sedation Training Module, presented by NAF Clinical Services.